Whether you're here for information on folic acid supplementation, or if you're a student studying for a biochemistry exam, or if you just have general thirst for knowledge, in the next 10 minutes, I'll go over everything that you have to know for folic acid. Let's go. The form of B9 that we obtain from dietary intake is known as folate, while the form of B9 we obtain from supplements is known as folic acid. And while there's two natural forms of folate, the monoglutamate and the polyglutamate, they would have to be converted to the monoglutamate folate form because that's the only form our body can absorb. Interestingly, the bioavailability of folic acid is much higher than folate, so supplementation of B9 is actually a really good source of getting B9 in your body. While folate can be found in many foods such as nuts, seeds, and grains, it is predominantly found in dark leafy greens such as spinach. And unlike other B vitamins that are water soluble, folate does not wash out easily. Instead, our liver is able to store a small reserve for around 3 to 4 months. Once in our body, the monoglutamate folate is converted to the active metabolite known as tetrahydrofolate or THF. From there, THF can be converted further into many different forms of THF, and it's the conversion between these forms of THF that allows THF to do its function as a coenzyme for many reactions. Speaking of its function, THF acts as a coenzyme for methylation reactions. If we take a look at 5-methyl tetrahydrofolate or 5-MTHF, you'll notice that there is a CH3 or methyl group attached on the nitrogen there. When acting as a coenzyme, this 5-MTHF will donate the methyl group, then causing it to go back to the THF form when there is no methyl group. The methylation reactions that THF is required for is broken down into two main categories. The first one is for DNA and RNA metabolism, such as pyrimidine synthesis for bases such as cytosine, thymine, and uracil, as well as purine synthesis for bases adenine and guanine. The other methylation reactions that require THF are within protein metabolism, namely homocysteine metabolism. Homocysteine is a metabolite of the amino acid methionine. In de novo pyrimidine synthesis, de novo meaning from scratch, the enzyme thymidylate synthase requires THF as a coenzyme for the methylation of DUMP to DTMP. In multiple steps within purine synthesis, the enzyme formyltransferase requires THF as a coenzyme as well. And in homocysteine catabolism, the enzyme methionine synthase requires THF and vitamin B12 as coenzymes to recycle homocysteine back to methionine. Let's put this all together. The monoglutamate folate that we absorb gets converted back into polyglutamate folate by the enzyme abbreviated as FPGS. The full name is on the top left-hand corner. The PG folate then gets converted to DHF by the enzyme DHFR, which then also converts DHF to THF. Tetrahydrofolate is then converted to 5,10-methylene THF, as you can see right here on the bottom of the screen, by the enzyme SHMT, which requires vitamin B6 as a coenzyme. However, THF can be converted to 5,10-methylene THF another way through the enzyme MTHFD1, which is why in people with vitamin B6 deficiency, we don't really observe anything related to folate deficiency because there's another way to convert THF to 5,10-methylene THF. 5,10-methylene THF will act as a coenzyme for the pyrimidine synthesis pathway for the enzyme thymidylate synthase, converting DUMP to DTMP. In the process, it itself is converted back to DHF. Alternatively, 5,10-methylene THF can be further converted to 10-FTHF or 5,10-methyl-THF, both of which can be seen here on the screen. These two forms can then act as a coenzyme for purine synthesis for the enzyme formyltransferase. In the process, they can convert it back to the THF form. Furthermore, 5,10-methylene THF can be converted to 5-methyl-THF by the enzyme MTHFR. And as we can see, 5-MTHF right there. And 5-MTHF will act as a coenzyme in the metabolism of homocysteine, converting homocysteine to methionine through the enzyme methionine synthase, which of course also requires vitamin B12 as a coenzyme. 5-MTHF itself is converted back to THF. This is one of the two main pathways of our body getting rid of homocysteine. This is known as the transmethylation pathway. The other pathway of catabolizing homocysteine is to convert it into cystathionine and then further into the amino acid cysteine. Both steps require vitamin B6 and the enzyme cystathionine beta synthase. This is known as the transsulfuration pathway of homocysteine catabolism. The recommended daily intake amount for vitamin B9 or the RDA increases with age, but is significantly higher for pregnant or lactating women. When it comes to B9 deficiency, the most common cause is actually alcoholism. But the most well-known cause is due to the increase in demand of vitamin B9 in pregnant or lactating women, causing potential deficiency, which is why it is a major part of maternity pills. The reason why pregnant women need to take folic acid is that folic acid plays a pivotal role in preventing neural tube defects, or NTDs, in newborns. A neural tube defect is the improper closure of the neural tube, which becomes the brain and the spinal cord. So it can manifest as the improper closure of the spinal cord, known as spina bifida, or the improper closure and containment of the brain, known as anencephaly. The thing is, folic acid or maternity pills needs to be taken right after conception, usually before the woman even realizes she's pregnant. Hence, it's commonly recommended for women to take maternity pills while they're actively trying to conceive. Another group of common causes for B9 deficiency is malabsorption caused by either alcoholism, intestinal disorders or surgery, as well as taking the drug phenytoin, which is used for seizures and epilepsies. Phenytoin blocks the conversion of polyglutamate folate to the absorbable form, which is the monoglutamate folate, which decreases the absorption of folate in general. Lastly, drugs such as sulfonamides, trimethoprim, and importantly methotrexate, which is used for chemotherapy and to treat autoimmune diseases, can inhibit the enzyme dihydrofolate reductase, or DHFR. As we can see here, the inhibition of DHFR by these drugs will inhibit our ability to make THF. Another interesting to note is the MTHFR protein, which is coded by the MTHFR gene. There are people out there with MTHFR gene mutations, as you can see here, based on their ethnicities. Of course, with an MTHFR gene mutation, it is now more difficult for the body to convert 5,10-methylene THF to 5-methyl-THF, which is required for the transmethylation pathway for the catabolism of homocysteine to methionine. The most important condition due to B9 deficiency is macrocytic megaloblastic anemia. Macrocytic refers to abnormally large red blood cells with a mean corpuscle volume, or MCV, that's greater than 100. Megaloblastic refers to immature nucleated red blood cells, known as megaloblasts, that are present in the bone marrow. There are also many hypersegmented neutrophils, known as polymorphonuclear neutrophils, that has more than 5 lobes within their nucleuses. One important note here, in vitamin B12 deficiency, we also see macrocytic megaloblastic anemia. The difference is, in B12 deficiency, there's also a lot of neurological symptoms and conditions that we see along with the anemia that we don't see in B9 deficiency. Another condition due to B9 deficiency that's also seen in B12 deficiency as well as vitamin B6 deficiency is homocystinemia. In homocystinemia, there is a buildup of homocysteine in the blood. This increases the risks for deep vein thrombosis, or DVT, as well as atherosclerosis, both of which could increase the risks for heart attacks and strokes. Ultimately, the high homocysteine levels in the blood can lead to high homocysteine levels in the urine, a condition known as homocystinuria, but in this case it's acquired because it's due to a vitamin B deficiency and not because of a genetic condition that you were born with. And of course, lastly, the possibility of neural tube defects in fetus in mothers who are B9 deficient. Again, this is due to a lack of folate in early pregnancy. As I mentioned earlier, examples of neural tube defects, or NTDs, include spina bifida as well as anencephaly. Folic acid supplementation is very common, and there are two main reasons why. Number one, of course, is for pregnant women or women who are actively trying to conceive. The second reason is it promotes cardiovascular health by lowering the levels of homocysteine in your blood, which lowers the risk of deep vein thrombosis, or DVT, as well as atherosclerosis. To be most effective, it should also be taken with vitamin B6 and vitamin B12, as they all play a role in the recycling of homocysteine. Other potential benefits of folic acid supplementation that's still under study is the possibility of treating certain cancers such as colon cancer, as well as aiding in the treatment for depression and dementia. While vitamin B9 toxicity is extremely rare, there is one potentially serious consequence in that it could mask a vitamin B12 deficiency. Think about it. Since deficiencies in both vitamin B9 and B12 can cause macrocytic megaloblastic anemia and homocystinemia, excessive amounts of folate can prevent the macrocytic megaloblastic anemia as well as the homocystinemia that's caused by B12 deficiency, making it appear that you don't have any vitamin B12 deficiency when you actually do. However, it doesn't prevent the other main problem associated with vitamin B12 deficiency, which is neurological damage both in the central nervous system as well as the peripheral nervous system. Let's compare the differences between folate deficiency and vitamin B12 deficiency. Let's first take a look at the risk factors. The most common factor for folate deficiency is alcoholism. For B12, it is pernicious anemia. And while both vitamins are stored in the liver, our liver is able to store much more vitamin B12 for much longer times. So it would take years before vitamin B12 deficiency can actually manifest, while for folate deficiency, it would take usually 3 to 4 months. In terms of complications, deficiencies in either of the two vitamins can cause macrocytic megaloblastic anemia as well as homocystinemia, which can then become homocystinuria. But vitamin B12 deficiency can cause methylmalonic aciduria as well as, more importantly, the neurological damage such as progressive peripheral neuropathy. In terms of drug interactions, vitamin B9 can reduce the effectiveness of certain drugs such as methotrexate, as well as anticonvulsants such as phenytoin and barbiturates, as well as antibiotics such as tetracyclines, and the antimalarial drug known as pyrimethamine. If you like this video, consider subscribing to my YouTube channel and also follow me on my other social media platforms.